portion of the deposition.
Yes.
Okay. I'm going to ask you to explain in the exact same words, if possible, and certainly as close to the substance as possible, in what manner, specifically, you explain the procedure that you were about to undertake to Leah Summers on June 5, 1985, in your office. And if you would, it's sort of an artificial situation, speak to the camera as if Miss Summers were the camera, so you'd be explaining to the video camera the procedure.
Right. Well, we'll just start out by acquainting the patient with the introduction to cranial ball and discuss the problem. We're speaking to a condition that is obviously not of a correct and proper cranial situation. We're speaking to a alteration from perfect functional conditions. It's a restriction of breathing, it's a headache, and a visible, palpable disturbance to the arrangement of the facial structure. So, proceeding from that, we begin to have the patient a complete awareness. They know nothing of the anatomy of the cranial ball. So we start with a little photograph, an X-ray, just a standard little illustration X-ray of the side view, the lateral view of approximately a 1 or 2 week old infant. I chose this one from a file that gives me a best possible normal. This is just to illustrate the complete open segmental situation that prevails on the human head at the time of birth. It's greatly divided and separated on all of its borders to give it the mobility and flexibility it should require to make its passage through the birth canal. Now, these openings are, the main largest one is across the skull, called the Coronal Suture. It originates at the back corner of the roof of the mouth. It goes vertically through all the structures, cheek arch, temple, over the forehead top, and down the other side. Very straight through the skull. And across the back margin of the roof of the mouth. This is called the Coronal Suture. The next important one is the horizontal suture through the eye frame. And it's the frontal maxillary, the orbital suture. It's horizontal through the eye socket, across the temple, over the temporal bone, which is the side plate, around the back plate to the occipital bone, and follows the same course around the other side. The structures in the base of the skull are heavier, more dense, more formed, and more complexly fitted. All structures above the horizontal line are formed from just a sheet of membrane that gradually collects its calcium to form it into a shell. At the edge of birth, it's almost totally a membranous origin. Let's say it's like paper mache. The only bone structure are tiny islands of calcium collecting in the center of each of the structures. So it's quite flexible and should be completely open and free. Now, the structure that maintains correct form in this very loose and unattached box is the internal arrangement of three bands of very tough fibrous tissue, called the intracranial membranes. There's a little band that originates above the bridge of the nose and it comes down, it hangs from the roof. Let's pause, I'm going to speak. All right, now, it hangs from the roof as a curving band that goes the length of the roof until it reaches just above the little bump at the back of the head. There's a little protrusion on the occipital bone at the back, at which point it has divided from a single vertical into two horizontal. These are fitted around the base of the skull on a horizontal plane that's level with the cheek palate arch at the water level through the skull. These three membranes are representing the genetic, racial type, family genetics carried to this offspring for its perfection. Its height, its width, its symmetry has to be his family's project. They serve as, you might say, guy wires. Their intent is, upon releasing the baby's head from the birth canal, is their intent and purpose to bring all these structures back into their level, oval, symmetrical, and free condition. They're attempting to do this. They're under an outward stress to accomplish this. Now we come into the problem originates. A tiny piece of bone that is, I point to the very lower of the side coronal suture at the back corner of the upper jaw structure, which would put it in the side corner of the roof of the mouth, at the back edge of the roof of the mouth. This tiny little nubbin of bone is called the pyramid process of the Palatine Bone. Palatine Bone is a little part of the plate structure of the roof of the mouth. It's described as being the size of the thumbnail of this person that we're working on. That would apply the same to an infant. That same little plate of bone is paired on the back third of the bony roof of the mouth. There are actually two little letter L's. Cross and form the back third of the roof of the mouth, and they proceed upward on the lateral posterior margin of the nasal space. The upper extremity reaches the floor of the eye socket, where they fit in a very crucial position as one of the mosaic pieces of the eye, of the orbital cavity. The little pyramidal process grows at the angle of the L and extends itself outward around the rounded posterior portion of the upper jaw, which is, I believe they refer to it as the heel, and sets itself upward in the coronal suture between the maxillary bone and the structure of bone directly behind it, which is a small arch of plated, well, they're called pterygoid plates. It's spelled P-P-E-R-Y-G-O-I-D. And they are downward extensions from a bone structure across the central base, which is termed the sphenoid, S-P-H-E-N-O-I-D, sphenoid. In appearance, it is a butterfly with its wings extended laterally. And the arch of bones have the appearance of being two legs on the butterfly. They form structure immediately behind the lateral coronal suture, as the maxillary bones form the structure head of that vertical line. The little pyramidal wedge pinches itself in between these two structures. Now we have, if I may just use simplest terms, mechanism similar to the parking brake lever in your car, where as you depress this lever with your foot or raise it with your hand, you hear a very audible clicking of a ratchet mechanism, which is a small tooth of metal fitted into a gear-like surface that fixes the pedal or lever in its position as it's drawn into compression. In this instance, it's the downward compressing force on the facial structures as they pass through the pelvic canal.
Just press the off button.
As the head is passed through the canal, downward compressive forces that disturbs the shape, symmetry, pressure equalities, and allows the little pyramid to slip into its binding position, which, similar manner to the parking brake of the car, is fixed against the return spring effect, and that distortion is locked on at that moment. Now, let's see if I can get back to it. The face, I wanted to remark pointedly when we're speaking of this downward compression. You've got to see and realize that the horizontal suture across the I-frame horizontally, crossing the vertical suture, which is palate over the top, very markedly, it isolates the face as a separate unit of bones. They're not attached to the skull at that point, any osseous structure at all. And it's this little, there are 7 bones that construct the box of the skull, but there are 14 bones, and I believe I will say 22 main joint structures in the facial group, which is referred to as an appendage, an attachment to the facial appendage of the skull. And it's the facial appendage that takes primary compressive force, passing the skull through the most restrictive circumference that it has to overcome in order to be expelled. A second influence comes to bear in the fact that the uterus is constructed with a twisting muscle body in the manner of a barber pole. And in labor, the contracting and shrinking of the uterus to expel the child is in a rotational manner. There's more force applied in twisting than there is in just squeezing. Obstetricians, my finding from 30 years ago, had mentioned in their works that in their observation, the babies tended to, now we're going to speak of a normal pelvic delivery and a normal face down head presentation, that the babies tend to present their face out into the world with their right eye, their right forehead, their right eye, and then their face rolls into view. That statement was repeated in many old textbooks. I don't think even save these old books unless the museum has them. With statistics, some would say 7 out of 10, some would say 9 out of 10. All the deliveries I assisted and participated in was 100% seeing the face turn out to the right. Now that's the mechanism of the rotation of the baby's head. Its function being, as the occipital bone clears under the mother's pubic bone, the baby's neck thereby can flex and follow the curvature of the sacrum, the posterior margin of the canal. But this rotation of the uterus muscle has caused the head, at the moment the occiput clears, the head turns and the nose is moved off the face of the sacrum into the soft muscle space referred to as the ischial notch, I-S-C-H-I-A-L. ischial notch, which is the space beside the sacrum and the round loop of ischial bone that we sit on. Now, this rotating of the head functions in saving the compression of the nasal and central facial structures, and we then complete our delivery on our left forehead, left cheek, and left chin. Now, this is almost universal. Photographing thousands of faces, we see the diminishment of the facial features of the left. The left nasal nostril is narrow, and as most common, the point of the right chin is more prominent. Our facial features show that we wear this distortion through our life, and I see it in every face I have to observe. This turning. Now, we got through with the nose bridge and the least amount of trauma. Orbital, central, frontal, skull. This will be in great varying amounts, very slight to very, very obvious. And again, as I illustrate the density and texture of the tiny structures of the baby at the birth age, that they are not bone, they are very easily compressed and squeezed, disturbed from their normal patterns, and then fixed with the pyramidal latch, are unable to expand themselves back out into a proper and normal species face. Our species divided in primarily three: the Occidental, the Oriental, and the Negroid, and there are some small proportionate differences in those. But in general, Occidental face is an oval that has very proper proportion. Anthropologists have measured skulls from all of the races of all the eras of time, many thousands of all of their diggings, and have come to a set of literally mathematical formula. An artist draws a proper human face with a little statement that the face should be 3 noses long. So that he draws 4 lines, chin to nostril, eyebrow to hairline. And these 3 should be in a proportion. That requires the little floating central face to be up in its proper positioning. We see great deviations of this. We see noses that are 3/4 of an inch shorter than this proportion because of the depressing of the central face in birth, tipping back of the central appendage of the face, and the latching in a position that will not allow it to, the intramembranes, to bring this back forward into its open position. In the application of our treatment, we see this gradually, steadily restored back to their proper proportions. The width of the face determined at being 4/5 of the length of the face, which is taken from the hairline to the chin and comes out to a point very close to the little eyebrow ridge in the center of the lower forehead. So a measure taken from that point to the chin should be the width of that ovoid frame in its proper, open, symmetrical form. When those conditions are met, all passageways for the entry of arterial blood and the exit of the venous blood, for the formation and function and draining of the cerebrospinal fluids, all the nutrients that that brain flesh has to have, are not impeded in any way in a complete, open, and free human skull. They are impeded in varying areas and varying amounts with these cranial distortions. Each of the large arteries enter through a suture, through a space in the joinings of bones. And the jugular vein exits in a suture between the joinings of bones. These openings, which determine the passage and volume of flow, are altered or affected by these distortions of the parts of the skull to impinge at one side and exaggerate at another point. These governing then the function of that brain as to whether it's getting proper oxygen or alertness, sensitivity, or whether it's in a semi-anesthetic state from loss of oxygen is the required volume. Now, we find that if we can release the impingement of the little pyramid latch, that these other forces are all released into play. They will move if the facial piece, as I will recall, as I said, I believe 22 articular parts, like a complex jigsaw puzzle, will make its movements as far as the freedom allows, at which point it will tend to impinge again. It does not go backward because of the expansion of the intracranial membranes at all times. Once you release the brake latch of your car, it does not go back into latch without a causative force. So each treatment of release of the latch is a positive release of the condition. It's administered in a periodic way to allow recovery, allow time for these expansions and normalizations to occur the best that they can. Now, we project this up onto an adult skull, same lines, same pieces. The infant is only very much smaller. It does not interfere with our application of the treatment to allow a distorted infant skull to release back out into a very beautiful normal skull. And whatever visible functions were shut down by the loss of circulation, oxygen supply, or the draining away of the toxic venous waste which result from cellular life there, when these are released, we see immediate effect changes upon this child. I mentioned the ears. It's a matter of the folding down of the cheek, which occurs to little quarter circles here, and they fold up and down like a little bucket handle, may I say it. And it presses down on the face, ahead of the coronal suture, and folds the cheek arch so that it impinges the structures forming for the eustachian tube passage. The tighter and more closed it is, the more venous, capillary, obstructive, congestive, the tube will swell shut. And without an airway to the inner ear, equalize the pressure to the outer ear, there's no vibration to the drum, and there's no sound. So we open that and restore the deafly in children. Each piece controls the function, or contributes to an interference of that function. Now, these bones of an adult do not grow together in normal conditions. It is generally supposed, because the issue is not commonly addressed specifically in early college anatomy courses, it's assumed that the head is a solid globe. I believe the dental field assumes that the whole facial appendage grows into a mass by approximate age of 16. There is available disarticulated skulls where they have, just by someone's expertise, been able to separate these bones all into their individualities without breaking or disturbing the tiniest little tooth-like projections on the bone. And gently worked with, those parts can be assembled back into a skull, which precludes the supposition that skulls are solid and built like a bowl. They're visibly movable, they're palpably movable, they're open at all times. Should that movement become impinged, the quality of function internally is immediately suppressed. Referring back to the passage of circulation through the articulations. All remember that the baby's soft spot is very visibly rising and falling. It protrudes anytime there's an exhalation, expulsion, to grunt, to cough, to laugh. Soft spot on the top of the head, phragma, will bulge when they exhale and drop when they inhale. This is a respiratory inducement. The brain is in the box, much like your foot in the shoe. It's not attached in any form. But its spinal cord, which is a large cable bundle that connects with every cell in the brain, exits through the skull through a large opening in the base, the foramen magnum, large foramen. It allows that cord to pass down through the vertebral canal as a tubular structure formed by the alignment of the vertebral column. It ends at about the bottom rib and the point, at which point the duramater and the tougher membranes of the cord are drawn together as a strong filament, or in Latin it's phylum, F-I-L-U-M, phylum terminale, the terminal thread, anchors the spinal cord, thread through the lumbar vertebral column, sacral canal, and is attached in the region of the coccyx, or tailbone. When the body inhales, the ribs must rise to accommodate the expanding lung, and the rising rib causes the spinal curvature to straighten somewhat, which straightening of a curvature would increase the distance between its ends. Remain at the center of gravity, this is accommodated in all the curvatures of the spine. So when you inhale, all curvatures extend and the spine is lengthened. And when you exhale, these curvatures are restored and the spine is shortened. You can observe people's heads rising and falling as they breathe, if you pay attention to it. This mechanism is called a strong downward pull on the spinal cord by the tailbone attachment, as there is a strong lifting against the base of the skull by the superior vertebra. This pulling, if you pull on the dog's tail, you pull the whole dog, right? Now, this pulling downward on the spinal cord causes a strong downward pulling in the central structure of the brain. This would cause the brain to become shorter and wider, which would make the height shorten. The skull is beautifully designed, and the sutures between the pieces accommodate that alteration by going into a flexion of the base, folding downward of the sphenoid butterfly, which causes the laterals to widen and the top plates to swing down as they widen. So there's a widening and a shortening of height and a tipping back of the center with an inhalation and a reverse of that with exhalation. Now, if that's perfectly free, the brain is then unfettered for a maximum amount of its function, or is termed a respiratory rhythm. Again, if the little latch is impinged and interferes with that freedom for that brain to make its excursion, inhaling and exhaling, it has, in essence, reduced the viable power of the brain. The brain generates the electricity that makes us the living creature with an electrical nervous system. And our vitality is directly proportionate to the freedom of this box. Some of us are very lucky and are very vital and vigorous and did not get locked very tightly, and others are squeezed into such a compression that they're total brain function to their total body is in a very weakened form. These are the qualities that we have to treat in the office. Now, any blow is transferred through the membrane mechanism, through the hinging, and will, if sufficient, will allow a latching from any direction. Blows to the back or blows to the front will cause a binding, shifting, and a latching. This immediately sets up circulatory interference in the immediate area and all tissues, parts involved. Now, we found that if we could just release the little wedge slightly, just to release the impingement, the binding effect that it has when it's forced in, like the tip of my thumb, would force in between my fingers. Now, if we could just get that little wedge to release the binding effect, these other factors immediately are released as your brake pedal releases when you just pull that knob slowly enough to pull that little ratchet tooth loose from its impingement and releases the compression of all the wheels and all the hydraulic mechanism. That's the release of the little wedge. It releases all the hydraulic forces, the cerebral spinal fluid, vascular. And this is often expressed in the patient by voluntary expressions of sensation through their whole body. We observe the correction of the symptom pattern, which is eyes involved with the 7-bone mosaic structure of the orbital cavity, and most commonly an impingement of the circulation to the eye, which enters in the back, large opening across the back floor of the eye socket, where the glass, where the carotid artery rises to the head with the fresh oxygen that this brain needs. I'll make a note that somewhere in physiology statements, the statement was that the brain and eyeballs burn approximately 50% of all the oxygen inhaled in the human body. They have this great demand for oxygen nutrient in order to make the rest of his body perform. At all times, it operates every cell of the body. Now, the carotid artery is the main supply of blood to this brain. And just before it enters the skull, it gives off a branch to the eyeball. So the eyeball actually gets the first sip of fresh oxygenated blood that rises in the carotid artery. And immediately internally, as the artery enters, there is one small branch, leaves it instantly inside of its entryway, that feeds our pituitary gland, which sits in the center of the skull, in a small declivity or cup. So that it is thereby the most important sensitive cellular structure in the human body that needs that access to that fresh oxygen and nutrition brought by the artery. Any time the facial is compressed, pyramidal wedge is locked on the pterygoid legs of the sphenoid bone, that freedom of the flexibility of the base is impinged to that degree, which impinges blood supply to the pituitary. It impinges a function of motion that's in the respiratory rhythm that the pituitary is dependent upon. And we see variations in growth, weight, and height, and texture throughout the whole human being as this is suppressed. We found that if we could just slightly release the impingement of the little wedge structure, that these factors would begin to be relieved in a period of time, totally unpredictable, because it's very quick with some and more protracted with others. These circulations are restored. These centers of brain function are stimulated, nourished, activated, whether it be in mentality of the forelobe, which is starving for oxygen and can't light its little lights up. Whether it's the eyeball, that when the face is impressed, it causes an impinging of the passageway of the blood supply into the eyeball, which greatly diminishes the acuity and vitality of all visual functions. Whether it's in the base of the skull where the cerebellum sits and controls all motor and muscle coordinations, including the intestines and the heart, the lungs, and the body's muscular activity, to direct your finger to its goal to scratch the tip of your nose. And these are the effects on cerebral palsy when that's interfered and impinged. Then the motor circuit, the motor conductivity to the body is interfered. Now, in the adult, as I have an example, which is just a plastic replica casting of the intracranial membrane that's responsible for the symmetry and the carrying of these motions in a proper form through the skull and the respiratory. And these structures are, this is level, it is a water level to the very base of it, on this level. And that is attached right around the bowl of the base of the skull, which is on a water level to the cheek arch, around the skull. This is a little arch for this little skull, but it's easy to slip it down into place to where you can visualize it. It's attaching along the ridges and the two little processes forward over the little sphenoid butterfly for their attachments here. This vertical surface membrane comes down, as I mentioned, above the bridge of the nose and attaches to a projection that's there for its special little plate of bone that attaches it there. And it has then the control of this skull on these three axes. We all have perfect species bones. Each piece in us is genetically correct, excepting obvious chromosomal variables. But in the general, we have human, Homo sapien, pieces. We are a species. We should be in this formula of similarity. There are amongst us representatives of more the perfection of what we should be, as we see them on the covers of the magazines and maybe in the movies. Well, no longer. They like ugly people in the movies now. But it used to be a prerequisite to have this elegance of feature and form. Somehow, very marvelous physical function always accompanied the person that had this elegance of facial form, which merely indicated they were level, they were straight, they were vertical, they were free, the brain was getting full nutrition, all parts were working, they would sing with no restrictions because there was no impediment to the areas and the little area in the left eyebrow that initiates all phonetic and speech, and which is very commonly impinged with this left facial birth presentation. Very easy to measure a declivity or a depression or a disproportionate relation of the frontal halves and know that the space behind that has been involved with the freedom of circulation, the proper oxygen nutrient to perform at its optimum fullness. Central facial bones of the facial appendage. I'm sorry I didn't bring along a bright little pen light, which I didn't remember to reach in my case and bring, but by applying a small pen light and by holding it to the light, you can literally see that the lightness and the thinness of the palatine bone. I won't raise out a camera. By getting a light behind it, the thinness of the palatine bone, the maxillary cheekbone is as thin as a sheet of this note paper. That is the thickness and texture of the bones of this whole central face. All of the bones of the eye socket, if I can get the light in. Am I out of range? Sorry.
When you're ready.
I'm sorry. I was trying to get to a bright spot of light. But if you can see light illuminate a bright flashlight will surprise you that these are, they light up the same as I put the light behind this paper, as the whole facial appendage group. Now, in life, they're not in a brittle form as this dried bone. These are extremely vascular, extremely moist, and extremely flexible. The central facial pieces have in their live form approximately the hardness of the ring of cartilage that forms the back ring of your ear. That saves us from the destruction we would have on brittleness with the blows and things that happen to a human face. It allows it to spring itself back, like a bouncing rubber ball, you might say. It takes quite a sharp and pointed force to fracture a piece of taffy, a movable saw piece of material. We see these cases where they have pressed the face in a wreck and distorted this rate. And again, by entering internally, slight expansion of air, we spring those faces back out into as near to their level and vertical and symmetrical in form, to where we often wind up with a face in better form after the accident and our correction than their face was before the accident. I have a number of these cases. Now, how are we going to release the little wedge? Many, many years ago, when I first became interested in this, and since it was not a catalog and textbook subject, that it grew together out of observations and experiences of many of the old doctors. It was a group of old osteopaths who took the first interest. And amongst them wrote the first little papers talking of the respiratory movements of the cranial ball and going ahead and making attempts with calipers to measure the motions and things of that nature. Now, unfinanced research is pretty limited. With unlimited granting, some marvelous literature could be produced. But we're so busy doing it that I do not have that body. Now I observed those early old osteopaths. He said, well, now that little wedge is fastened to this little square, and that square forms the back edge of the roof of the mouth. And by golly, how can I get to that? I could just stick my finger up behind there and hook it in over the palate and draw down on it. And those that tried it obtained some amazing results. But once, because nobody submit to a horrible thing like this a second time. It's a fingernail. There's a bulky finger. So it was very obvious that wasn't anything that I wanted to be part of. I observed that being done. Even attempted it briefly myself. And had it attempted on me. So when I became aware that there was a small inflatable device, now don't ask me for the origin. It's like who invented the wheel? It's given to understand by one old gentleman that it was shown to him by an old doctor that had come from Germany back in 1910s. But it was done without any consideration of a correction of the skull and the facial parts or any of that. That was before they began to observe and record these factors. It was merely placed in the nostril in very, very thin form. One finger cut, which is so fragile that its expansion is so loose. And their theory was, you've got to get through that little opening. I'm sorry that the septum bone is missing from this skull. This is an illustrative skull. People handle this skull. It's been dropped, and some of the fine little pieces are missing. but there's a little plate that divides the two sides. There's a nose septum. There's 14 bones. If we count the septum and the central bones, we would describe 9 bones as being involved with the structure of one nasal space. And since the wedge is attached to the plate forming the floor of that posterior opening, they just pumped it through, hoping to spread some. At that time, at first, they weren't even interested in the little wedge. They were only interested in getting some air through the nose. Maybe they moved the mucus aside enough that air would go through. And it was impressive. The patient would say, "Oh, I haven't breathed." Well, that's the way they were applying it. Now, it was very crudely done. They pumped the little balloon until it came out through the mouth, and they just merely popped it with a pin. Now, these were elderly doctors who were attempting this work. That immediately was abhorrent to me in the practical and anatomical understanding of the structure, that when you have passed the restriction to the inflation, that's all that you required. You have overcome the restriction. Then the necessity of going through the mouth was totally superfluous and abhorrent. So we practiced and worked the technique until just as soon as it has, you see now I'm jumping ahead without explaining the inflation, all right? Just drop back there a little bit. I don't have my mind right on a patient case sitting in front of me. I'm trying to do this in an orderly manner. That we found then that relying on one of the basic laws of physics and chemistry, which they're called Boyle's and Charles' laws of gases, which every student has to learn in chemistry. 3 variables: volume, pressure, and temperature. And the one law statement that air in an expandable container, when air is applied in an expandable container, the pressure remains constant and the volume, the pressure and temperature remain constant and the volume is the variable. See, there's 3 variables you can have. So relying on that pressure, constant, equilateral in all directions, was the exact application we needed to attach under the best inflatable device we could find, and we searched everything, was surgical glove quality latex finger cuts. These are commonly used to cover a finger for a cursory examination where sterility, and a non-invasive to check a mouth or a throat, a tonsil, an orifice. So they're of surgical latex quality. Now, in other words, production quality control is equivalent to the need of good latex gloves for the surgeon. So these are procured. Now, air in an expandable container expands equal in all directions. Now here in the air, in this space and unconfined, well, it's only the variable on the little rubber form, but the air in here is equal in all directions. So if we apply it, again, let's use lay talk, the inner tube of a tire on a car. It only takes a small amount of air to exert sufficient to elevate the car and support it on a rubber cushion. So a slight amount of increase of pressure when it's in a confined space exerts its force equally in all directions. What have I done? Oh, here it is. There. I exert it equal in all directions. Now, if you can see what happens to my hand while I'm doing this, I'll clench very tightly. Now, this is far more than you would ever see in fragile facial construction, because all of these, you know what delicate structures there are there, and so you know the limits of the type of force is tolerated there. But it makes my whole hand expand in all directions. It expands outwardly. Now there's 14 pieces in this space, and there my hand represented 4 times 4, 16 pieces. But when it is sufficiently expanded to overcome this compression that's locked on it, to allow the, may I enlarge to this for visibility, we have the upper jaw, the middle pyramid, and the leg, the pterygoid leg of the sphenoid. Well, I'll use the other hand so it's visible to you. Now if I could lay the little, now we're assuming we're inflating this space. If I could lay it just the length of the palate so that it's right in the little orifice, then give it a little compression. It expands, it overcomes the compression of the group structure and allows the little balloon to pass over that edge and displace or release that wedge in a downward manner. At that moment, it's very common to see flattened cheek swing out into a rounded form, or a flattened side of the nose to rise up toward its peak as this thing releases out. So it is deflated, extracted, placed in the opposite side, and reinflated to expand the opposite side. Now there's always one side tighter, one side looser, as precluded by the birth force. So we begin our treatment, right side where it's least involved, and get some stress out of that, which lets pressure off of the spring mechanism. Then we go to the second, and it releases. As small children, 3 years old, take this treatment repeatedly with no bonds, no fuss, no holding down, and it is applied in passing through because the space is divided by some lateral structures that are called the turbinate bones, and they're curlicues, they're like rolled leaves. So that as you look into the skull, you're looking into a scroll-like structure of divided nasal passages. They're marked on here with they say A and B and C, denoting the inferior, medial, and superior nasal turbinate passages. Meatus is the word we use, M-E-A-T-U-S. Now, they relate on our skull for our purpose of the structural effects, in the lower passage being the level of the palate, which has the pyramidal latch in its corner, and onto the base of the structures of the skull, on through that base. The medial passage is on the level of the cheek arch, back through that head, as I just showed, a water level of the cheek arch, which is carried internally on the same water level around the basilar bowl of the skull, the occipital bowl. The membranous attachments are on the level of the cheek. This level is level to the cheeks. So we release the medial passageway. We are releasing the stress that's around the marking bowl of the skull, which was visible, having crockery, a bowl under here, and a thin dome lid over the top across that line. That force is released. On initial cranial examination, we will quickly just check the amount of distortion right or left in the base from the mastoid to the eye, and it's very common to find that an inch and a quarter in the distortion by the left compression. And by the time we've released the lower 2 passages to release the latch, and the second 2 passages to recompress the stress on the basilar membranes, we will reach up and find that this skull has almost returned to a symmetrical, regardless of age, whether they're 3 hours old, whether they're 85 years old. This is living, cartilaginous structure, and it will make these corrections. We then proceed to the superior passages, which are narrow and high at the orbital, bridge, cheek, frontal line. And we inflate across there to release the suture, which is through the eye and over the temple, or is visible on this real skull, through the eye, across the wing of the sphenoid butterfly, out over the tip of the butterfly's wing, over the temporal bone, across the mastoid notch, around over the, I'll put it here so it's visible, it's around over the occipital plate, back across, over the temporal, back through the orbital. Now, when we reach that upper passageway, we see visible releases. It's possible to stand there and watch these changes, or put your fingers on them and feel them. And it decompresses the upper plane of the skull. At that point, now at each time, we are inflating a right one and a left one, and we are stopping. We move immediately eye to eye with the patient so that they don't wake up. This is a startling sensation. How many times in your life have you had anything other than your finger in your nose, or air or water? That's the limit. Their mother spanked them and told them not to put the crayon in their nose. It was a no-no. We're all raised with this nose being an absolute no-no. And having been left like that, it's never been discussed or measured or written or recorded any different than that. So people treat it like it's a totally unknown factor. So we show them how quick and easily these things release, how instantly they have an magnification of air spaces and release of pressures. Many times the headache quits when the first pass and the latch lets go and the pressure is released. And they can bump the head and say the headache is gone. So we're watching the psychological effect. Every patient is so totally an individual. I do not have handout pamphlets like how to board the bus, because every case is an emotional, structural entity onto its own. Anything I would give them to read prior to that would be a confusion. They have been sent to me by word of mouth, always a referral. I have no drop-ins. How would we find out where it was? They have been sent by others, by the doctors, by other patients. I've referred to come for this treatment. So I talk individually to them. I explain this individually to them. I have explained this to every patient that ever came into the room. We set the 45 minutes to an hour aside and charge the $75 fee for that time, just so they are well educated. They know exactly what the structure is, where it is, how it is, what we're going to use, how it will be used. We show them the inflation. We allow them to squeeze it if they're curious, or I'll squeeze it in their hand if they're curious. We don't proceed. And sometimes if people are not of an attentive type, I have to maybe drop to my knee and get the baby's head under their eyes, or I may have to touch their arm and direct them toward what we're pointing at, or hold their position so they will see as I point that these passageways are natural to all of us. They're ticklish, they're a little sensitive. They are pink and vascular, like the lining of your lips. And that the little balloon passes just over the edge of the bony palate, and they feel it touch their throat momentarily. It's a very quick little squeeze they feel. The children will get up and say it feels like jumping in a pool and getting a little pop of water into their nose, which instantly blows away with a much improved, much opened space. There's almost invariably immediately great release of mucoid matter and sinus drainage and opening up and the releasing of the circulation. So then, on the table, now we have done all of this in a standing position. I have this on a wall beside me on the right. These others are in a glass case by two chairs. And so then I proceed them over to where they stand to this purposely brought them to stand to it as I explain it, and then I say, now we would like to take a front and lateral view of your face as you are, as a comparison for what changes you're going to see happen as we're predicting them to you. The cheeks will rise upward and outward toward a level motion. We will begin to move toward our proper dimensional orientation. I sit them right there on a stool, a dark blue wall for good contrast of photography. I usually, on their first visit, grab a little yellow sticker exactly of this type and write their name, bold in black, and put it on the wall beside them so that their face can be filed by the employee. Okay? From that point, we get our right and left face views. We move over onto our table, which is a large hydraulic pedestal. This is an osteopathic type manipulating table with many articulated segments and so forth. And we have them on a feather pillow with a paper cover. And then I get them acquainted to the touch of their head. I will show them the deviation of this measurement. Now we measure them with instruments, but I'm talking 36 years. I could quickly show them, or I can have them feel it, or have the mother glance down as I hold my hands and see how much longer this is and this is back. All right, we acknowledge that. Then I show them that any place that the suture is in an impingement. You see, if I were to spring the base and cause these to jam to each other, there is a little ribbon of tissue in there. It's a little lubricant cushion. It's very, very vascular. Some of the scalp nutrition comes out through there. As you see, balding follow these suture lines, usually starting at this one, and then this one, and then they work together. So we show them that any place these are impinged or squeezed, there's going to be a sensitivity to touch them, with just a little finger pressure to go down over them symmetrically. There should be no pain on an articulation of the human body. It should be free and fresh and functional, unless you're chemically off and have rheumatism or something like that, or a hurt cell. So the head should be free of all sensation here, but we start down the coronal suture with a tiny fingertip, and as we go down the frontal segment here, it's all right until, I guess I better put this on momentarily. Just found out that these are no longer, you cannot buy any bone skeletal structures in the United States as of now. They're all going to be plastic from this point on. I was going to go buy one to bring along a fresh illustration. As I go down with touching pressure, down over this, we watch very closely for the eyebrow, the eyelid, even the pupil, to illustrate a response of sensitivity. And we're looking very closely at their face as we come down over this. Well, just as we reach the line, sorry I don't have a chalk that I could make this more visible to you, just as we reach the cross of these two sutures, which is right on a pointed tip of the wing of the sphenoid butterfly, their expression will immediately react invariably on the left side. 98.6 times it's the left facial birth compressor. We come down this side and suddenly they're into that compression pain. On pressure palpation, these structures have a giving, a semi-right melon feel, a giving, not a rock hardness. We see rock hardness when they're jammed in so tight and jammed so tight. This is common to our cerebral palsies and quite a number of the retarded, where they're just closed in there like they're wearing shoes much too tight and their toes are numb and tingling without sufficient oxygen to keep sensory functions. All right? And we'll find that the left temple will show the first influence. The next thing I will show them is how free and flexible a little pressure on their right cheek arch is. And even the right side of the nose bridge is very flexible and giving, like a cartilaginous structure. So we compare by pressing at the left facial arch, and it will be as solid as a stone, and it will not have a sharp pain, but it will have most usually a dull bruise type feeling. And then I reach and attempt to move the left side of the bridge, and it will be as solid as a bolt set in oak, in this being in a jammed condition. Now this is universal. It would be that if I checked each one of you. Then I will quickly slip on a fresh finger cut and say, I want to palpate the roof of your mouth. Just breathe through your mouth, please, so that your tongue won't touch my finger and exaggerate a gag. And I will just press, and I will just palpate this. We'll find great ridges of bone that the dental people call torus palatinus, a turbidity in the bone that has caused a great formation of, what it does, the compression of the skull on sensitive areas has caused the bone to build a callus there. It just packs up a lot of calcium until it can actually hold that compression. I found them in a 5-year-old child as big as my little finger, glued to the roof of their mouth. Again, now, there's no compression in the front of the face on the palate because there's a crack up the center and the pressure can get away. If I press there, it doesn't impinge anything. I can usually show them now. I can press the front of behind your teeth, sufficient to make your whole body move on that table. And no sense of pain at all, although there's a very large nerve, comes through a very large opening behind the upper front teeth. It's not an impingement. But then I say, now I'm going to gently touch your palatine bone. And so just as lightly as I could reach in and touch it, they flinch instantly as though I'd used a pin or a sharp point of some type sensation, where it's under the compression at the back of the arch. And I show them that the right pyramidal wedge is almost universally never has sensation when I press on it, but that the left one has a sharp, immediately flinch expression of sensitivity. Now, I have shown them sensitivity in their left temple, on their left cheek, in their right palate. So then I go to the main sutural motion point of the occipital mastoid, and right there they have an extreme pain. So it's like they have an arrow stuck through their apple, from the left temple to the right base, and it touches these 4 points. Well, we find that makes a circular line as though there was a torsion or a twist in the structure due to this left birth presentation, and the latching is all in the right palatine. Now, when I've made them aware, so that they definitely realize this pattern of locking and pain sensations, then I explain to them, now we will go ahead and release these. I show them the little, again, I repeat, so that they're not thinking that I have reached behind me and got some foreign object. I put them directly in front of their face. I say, now we're going to apply this little air compression. The last thing I want from a nervous tender child or a tender nervous adult is for fright, because they lose all rationality. They lose everything. Their eyes turn blue, and they start hollering and thrashing, and then you have to wait until you get them focused back to reality again. So we let them see it, and we approach it, and we let them feel it touch them. I'm talking this through them. I said, now please take a breath and exhale the breath through your nose, and as you blow air outward, your sensations of expelling will disguise the sensation of my little slipping in there, which is merely a matter of putting this into that space right there, putting the small toothpick into a space as large as your little finger. Now that toothpick, of course, has a minimum of 4 layers of this rubber over the end of it, because it's just used as a small guide to insert. I will say, take a breath, now blow it out your nose. Can you see this without, see? And then, maybe if I turn this way, and then I catch this, and they blow outward, and with my finger, my hand is in contact with their face. And these two are just working between themselves. And I will just slip this back as they blow, it slides back, and I immediately extract the toothpick. And, pardon me, that's not staying in place. I thought I could show you then the appearance of the end of the little balloon. May I get rid of this top before it falls off? That the little balloon just appears there at the, just it appears, laying there soft in the posterior end of the nasal passageway. And we stop and we discuss that. Now, you see, I've removed the toothpick. The little balloon is in place. It's at the back, and I'll reach up to the wall and I'll point so they can just turn their eyes and see that it's at the posterior of this little tube. I want you to put it in your mind. Now, it's not in your ear or in your sinus. It's just in that little tube. See? I'm talking to eyes. Until those eyes show me they comprehend, I don't make my next move. They must comprehend. Now, if you take a large breath, now while they're inhaling, you see, it just goes right in. Now then, I said, you recall that I told you, every time you inhale, the base of the skull flexes, all pressures are expansion. The force in the membranes are immediately placed into an expansion mode. As you inhale, the head widens. As you exhale, it narrows. So we want all these forces in play. Inhale deeply, please. Now hold that breath and one quick little inflation and out, just like that. They feel that slip over the back and it's out. Now that's a little startling. They've never felt such a sensation. Their brain will say, oh my God, what's that? I've been slapped and bumped and scratched, but I've never, my brain does not record a memory of this. So then I said, well, do you remember your first jump into the water and how startling it was to get a nose full of water? Give them conscious comparative values. And I said, now you see, and instantly the breathing capacity is greatly enhanced because all of these soft tissues expand outward instantly. So I said, now, that's what the general feeling of this thing is. Now I have moved around, so I'm talking straight in their face, and they don't see me in some grotesque or distorted manner. And then I swing back beside, and I said, now we're going to do the same with the other side. It will feel approximately the same because the primary latch was on the right side, so the left side, in general, should slip through freer. Not always, but in general. The predominant group will definitely show more tightness and resistance on this side. Now, this one shoe is a little tighter than the other shoe. So, we inflate the other side. I have placed ample Kleenex in their hands. I will say, now this is going to make your eyes water. This may make you sneeze. I try to precondition. I don't even squeeze the bulb until I've reached up with my fingers and put a spread and said, now it's going to feel like this. It's going to feel like something just squeezes or spreads against your cheek, a quick little puff. And you'll feel that little bubble just release down behind your tongue, just in a quick little puff like this. Then we stop, we blow our nose, we catch our breath, we discuss it. I watch their eyes closely, and a good 60% of all, whether it's an infant or an elderly, express an immediate release. They release their apprehension. They found out that it is not a surgical procedure. It is not an injection of a hypodermic needle into their flesh, or they found that it is similar to an experience of swimming. The sense of pressure, the sense of momentary stoppage, and so forth. And then I say, now, shall we proceed? And I'll ask that always as a question. Shall we proceed? And we will go ahead with this. Well, let's see, I don't know, that's pretty scary. I don't like that feeling. Wow. Now, wait a minute. Now, let's just be rational. Look at it. You're not bleeding. You can fade anything. Now, are you breathing better? Let's try one note. We try to bring their mind to a focus here. Who ever thought about this? Unless there's a pimple. Whoever stops and thinks of this? Unless you're severe enough to live a restricted, conscious, can't breathe, or have a sinus pressure type people. But they all have this compression, whether the focus is there or not. So then we proceed on that basis. We spent nearly 20 minutes doing the young lady. stopping for that nervousness she has, trying to get those eyes focused back, constantly pointing back. Now we're going into this one here, and it's big as the other one, and it'll feel exactly the same. You cannot tell the difference. Oh, you can tell I'm above, but not in there. It'll be about the same little thing. Very quick now, and I'll reach up and I'll squeeze the cheek again. I'll see just very quick like this. Get them focused. Here, just blow your nose some more. That blows the air, it cools down that touch sensation, you know. It blows away that rubbed sensation or that water splash sensation. And we can proceed to the next one. I cannot, she made the remark of going to the restroom. I cannot recall those details because of this excitement. But we did proceed with the next pair, the medial pair, and yes, could breathe better. Then, we're ready. Now, shall we proceed with the next one? Yes, it was higher. Yes, it is tighter. Yes, it is 30-some years of extreme sensitivity to my fingers to know whether it's here or there by the compressibility of this thing and the quick release I have with this thing. I can make that fill or release that quick with my finger. The only way we can determine the actual tightness is try. Let's see how it is. The upper right one was a little tight, but it did. It flipped right on through. But it's quite a bit sharper. The nerves of smell are here. The sneeze nerves are here. There's a little more alertness to that up there than there is through these lower ones. And that one was finished, and she was expressing her nervousness. Again, I'm taking the time to try to calm all of this, and then we move toward the upper left one. It was tight, it was narrow, and by the time I could even determine whether it was a freedom to pass, she felt that sensation building up, and she lost it. She went to grabbing, and here I have it in her nose. It is inflated. I need to release this and deflate it, and she has pulled my hand off while it's in an inflated position. And I'm getting here, so her husband just took her hand back while I released this, and the other doctor who was sitting in the corner just reached forward and steadied her shoulder like this. He didn't leave the little stool. It's 3 feet away, and held that shoulder. I released this and took it out. It did not pass through the passage. I would not have any way forced it to. To what gain, to what avail, to what necessity if we got the rest releasing? We do this every day, any day that we find this type of angular fixation. It's not to my advantage to force anything on anybody. That deters their willingness to come back and continue the releasing program. But at that moment, she totally lost her cool. She threw us all aside and just bolted out. I understand she didn't run out. She just walked out purposefully and went out to the pond in the front. That's the last I saw of the lady. I did not complete. Now, under normal circumstances, I was saying in my introduction, do the lower pair, catch the breath, clear the nose, calm the person. You're okay, fine, we'll go ahead, good. We do the middle pair, the same, clear the nose, blow the nose, calm. And now shall we continue? And we would do the upper pair. And then I would say, now, the middle turbinate bone is a separate little bone. It's a curled leaf. And it's attached like it has a little hinge line down its back side of the wall here. And when I went over the medial passageways, we know we tend to put it into a depress. And then we go ahead and finish the superior and say, now, I know I must re-elevate this, so I finish my treatment by going back and repeating the first two, a right and a left, to establish this opening and leave the last thing left, the little latch, free as it can be. At which point, the face may You'll have it widen, the cheeks will become visible, these little rings under the eye may visibly leave, or this little tab in the corner of the eye may leave as the bridge springs up. It has only one effect, a gentle outward expansion from a compressed position toward a free position. Anytime you can take a bent circle and make it round, you've done it no harm. You've released the compression. That's the purpose, that's the application, that's the intent, and I can show you hundreds of children from the age of 3 and up who will immediately stand, turn, hug me, and kiss me, and show me their owie, and say goodbye. There's no trauma, there's no hurt for that child to come back and face this invasion a second time, and a third and a fourth, until they argue amongst themselves, 3 sisters. You were first last time, it's my turn to be first. Because the first one done is not going to worry, see? All right, and I hope I've explained that to you exactly as I'm telling you that I would like you now to please lie down, and we will proceed to expand your nasal spaces and release the compression on the eye. We see the glaucoma pressures start to reduce from the impingement of the drains of the fluid from the eye. We see the headache start to drain. We see the ears start to open and gain air, because it's an unlocking and expanding and opening and a releasing. That's the whole nature of the treatment. Now that's the head of this human being. At which point we go ahead and take into consideration the other problems. We want them to stand in a straight spine and a balanced body. I give them manipulation and adjustment to square up the pelvis, to level the hips, to stand the spine vertical, because if it's scoliotic, then we have other forces to bear on this floor structure. It's to our advantage to have that whole body as lined up and as free as the skull, and a symmetrical, physical piece of machinery. So, cranial is one of the adjustments we do to this patient. It is, they have to come into my office as a cranial case, and then I take care of that body that's on my table with all the needs that's involved with this.